I would like to introduce Dr. Melanie Brandabur, who is needs no introduction since she's had the microphone in her hand 2 or 3 times this afternoon already. Dr. Brandabur is our medical director. Is that correct? No, clinical director. And Dr. Jim Tetrud is actually the medical director at the clinic. And I think they flip a card every day to see who's in charge or something like that. So without any hesitation, I'm pleased and honored to call them colleagues and introduce them to you this afternoon.
So Dr. Brandabur and I are going to kind of answer some questions on the side effects of medications. We know that a lot of the medications we have really work very well, but on the other hand, there are some side effects. And the bottom line is, balancing the side effects with the benefits, and the benefits have to win out. So I had a handout. Does everybody have a handout that I gave? So. What I can do is just simply have questions. Maybe what we can do is to, I guess raise your hand, or probably writing them down is not a good idea. So, does anybody have any specific questions on side effects? Okay, so let's. Yes.
You list psychological effects. Hallucinations, delusions, and delusions.
These are under the neuropsychiatric side effects, and hallucinations are seeing things that are just simply not there. Delusions are images that are created from other objects in the environment. For example, looking at a telephone pole and it turns into a human being, or a giraffe or something like that. That's an illusion. Or some clothes draped over a chair turns into a person. That's an illusion. Delusions are misinterpretation of who you are, paranoia. Delusions like thinking that you're the king of Spain or that sort of thing. That's a delusion.
Unless you are.
Unless you, of course, are king of Spain. Okay.
And the question is, how often these occur and
how often do they occur? Well, they occur not infrequently. Maybe I could have Dr. Brandabur actually add to this, but they're really related to the patient's cognitive status. If there's a cognitive decline, these symptoms can come on much more easily. And some of the medications that we use may be more inclined to induce these psychiatric side effects, particularly anticholinergics like Artane, Cogentin. Some of the bladder medications, unfortunately, do this, amantadine, and the dopamine agonists probably more than levodopa. So that's why, as our patients get older, we tend to treat them more with levodopa, carbidopa, levodopa. Dr. Brandabur, yeah?
I just wanted to add that in some of my patients, when I use the word cognitive, they don't know what I'm talking about. So cognitive kind of refers to sort of the processing centers in the brain, so your thinking and memory. Some people with Parkinson's, as they get older, will start to have problems with memory and some thought processes and so forth. And it seems to be the combination of those changes in brain function with the medication. In other words, most people in early Parkinson's would not get hallucinations from taking a medication, but 20 years later, the same medication might cause some of these things. And I just wanted to add it's interesting how clever our patients are. I had a patient who was having a hallucination one night, and he decided that because some patients will have insight, they'll know that what they're seeing isn't real, and some patients really buy into it and get frightened. So he decided he would take a digital picture of the hallucination, and if it showed up in the picture, it was real, and if it didn't, it was a hallucination. I thought that was amazingly clever.
In regard to Azilect, it says that the adverse effect of carcinoma, how frequent is this occurring? Correct.
Okay.
You mean the fact that it shows up on the labeling? You mean that it's on the package insert, or when you look it up on the computer, it says that there might be an increased frequency of skin cancer? Okay. I'm gonna take that one.
Okay, well, to the best of my knowledge, Azilect is not associated with cancer. There is a higher incidence of melanoma in Parkinson's disease. Whether that is related to medication or not has been controversial for a long time. I think the general consensus is this is actually part of Parkinson's and not drug-related. I'm not sure if that's absolutely been clarified.
It's not melanoma that was listed as an adverse effect, it said carcinoma under skin.
Yeah, I think that's what they're talking about, though, is the melanoma. Almost every drug for Parkinson's that's dopaminergic has that somewhere in the labeling, even levodopa. And so actually, now, we do a lot of clinical trials here. And by the way, the clinical trials table is in the back. And if you're interested in signing up for to see if you'd be eligible for any studies, please talk to Renee or Liza back there, because we have an unprecedented number of studies going on right now. And in almost every one of these studies, we have to either do a skin check ourselves or send the patient to a dermatologist, because all of these drugs are trying to manage to get on the market without that on the labeling, because of course it's frightening for people. So the consensus is that the average incidence of melanoma in the population is about 1%, and that people with Parkinson's disease, it probably goes up to 2%. But it's still very, very murky, because the way they got the number for the average rate of melanomas is apparently by inpatient cancer patients, which does not seem to be the most generic population to study that in. So it's still a little bit murky, but there's no specific evidence that for sure the drugs cause it at this point.
I noticed the last year cognitively, I'm struggling a little bit with things that require steps. Would that be more the medication or the PD itself?
Well, that's always a really good question. We're always trying to figure out, did we cause this with our medication? Oh, I'm sorry. She's saying that she's noticed the last year or so that she's having some difficulty with mental tasks that involve sequencing, doing things in steps. And this is a very, very common complaint in Parkinson's. So we're always trying to figure out, as she is this caused by the medication or is it caused by the disease itself? And so if you do neuropsych testing on early people with Parkinson's, it turns out that most of them do have some very, very mild cognitive impairment. And again, that's changes in the thinking and processing. And so they describe what's called executive function changes. And one of those things is the sequencing. So trying to do something that involves steps, like plan a trip or plan a dinner party. One patient, a really good example, very meticulously counted out the number of pills he would need on his trip to Hawaii. He got to Hawaii and we had an emergency call from the pharmacy because he forgot to put the pills in the suitcase. So this kind of thing, things that involve multiple steps, so-called multitasking, all of these things tend to be a little more difficult. Doesn't mean you're getting Alzheimer's or becoming demented. It's just one of the things that can happen to some people in early Parkinson's. And the medication sometimes can make it a little murkier too. Do you have anything to?
Right, exactly. So as you point out, if you're taking any of these drugs under the anticholinergic list, those are drugs that probably should go first, tapered. And that's another point, is that anticholinergic medications, a lot of people are Artane and amantadine or Symmetril. And those drugs need to be tapered because there is a fairly distinct wearing off or withdrawal effect. And people get much worse, so you have to taper off those drugs.
Can there be problems with interactions with other drugs on any or all of these drugs?
Oh yes, do you want to take that one? Can there be problems with interactions between any or all of these medications?
You mean the medications I have listed under medications?
For other diseases?
Blood pressure, things like that.
Yeah, exactly. So one of the problems is with Parkinson's disease, a system called the autonomic nervous system is affected. But in addition to that, medications that we use for Parkinson's can affect blood pressure to some degree. So when a person's on a blood pressure medication, you have to take a look at, all of these drugs because they can all have an effect on Parkinson's because you're prone to have low blood pressure or blood pressure swings. So that's one of the major side effects we see actually in the clinic.
And I think the bladder drugs you mentioned too. The bladder drugs are supposed to be peripherally acting, meaning they're not supposed to affect brain function, but a lot of the times they do anyway. So since a lot of people with Parkinson's disease also have urinary difficulties of one kind or another, and they also get put on these medications, it's something you have to be very, very careful with because they can cross into the brain and cause confusion and things like that.
So these bladder drugs, ditropan, oxytrol, Detrol, those are some often commonly used drugs to help bladder function, but unfortunately they do have this effect similar to Artane.
There's another question. Oh, yes.
I have a question on medications A. The levodopa, that is replacing some of the brain cells.
Oh,
this is
okay.
a
Well,
fun
that's
topic.
a
Okay.
good question. Now that you asked that question, so the question actually relates to the potential neuropsychiatric side effects, and we've talked about hallucinations and delusions and so on, but there's another number of side effects that can occur, and this actually came about when we were studying the dopamine agonists, specifically Mirapex and Requip. And this took a while to really come to the fore, but these are also symptoms that can occur with levodopa. They're the impulse control disorders, and this is, a number of you have read about pathological gambling. The people who, never would go out and gamble, suddenly are gambling their money, their savings away. Hypersexuality is another. Compulsive buying and binge eating, which is, I think, much more common than I have here. 4% people with taking the dopamine agonist seem to crave food, and weight gain is a problem. This is one of the side effects, and then there's the dopamine dysregulation syndrome. I'm not sure where they came up with this other name, hedonistic homeostatic dysregulation. This is, I think, a British group that came up with that term. But they're the same thing, and this is more likely to occur with levodopa, where the impulse control problems are more likely to occur with the dopamine agonists. The dopamine dysregulation syndrome is an addiction. Some people, a small percentage, will become addicted and start increasing their dose of cinnamon to a point where they're having these wild swings of dyskinesia and off time, and that can be a real problem. Trying to decrease the dose of levodopa. This can be associated with something called punding, where people do repetitive tasks over and over, and they stay up all night on the computer. And that sort of thing. It can be very disruptive socially and for the family. So it's very important that as neurologists that we, when we put somebody on a dopamine agonist or see signs of these side effects, that we right away inform our patients and the caregivers about these potential side effects. Dr. Brandabur?
Yeah, I agree. I think that one thing that's happened is that I think originally we thought this was a very rare side effect, this compulsive behavior, because we just didn't hear about it that often. And I think we didn't hear about it that often because it's so weird. If somebody gives you a pill and you go home and throw up, they say, it's that pill she gave me. But if you go home and say, let's go out and buy lottery tickets and let's do the same thing tomorrow and the day after that, you don't think, I bet that's a drug side effect. You just don't. So I had patients for a while that had these severe problems, and a lot of times we didn't hear about it until it became really severe. Like, one guy came in and said, my wife is leaving me. And I said, why? And he said, because I'm gambling away our 401k on internet poker. And I said, oh my gosh. That was the first I heard that he had developed any compulsive gambling. And another woman who wouldn't show up for her appointments, and it turned out it's because she would have her copay in her purse, and she would pass a store that sold lottery tickets, and she would feel compelled to stop and buy lottery tickets so that every dollar in her purse was gone, so then she didn't have her copay, so she didn't come for a visit. It took me a long time to figure that. I thought there was another reason why she was missing her visits. So now that we know about it, I tell each and every patient about it, and we discuss it frequently, and I try to make family members aware so that this can be monitored. And sometimes that's all it takes. If somebody's gets a little carried away with internet shopping, and the two of them are keeping an eye on it, that can kind of be kept under control. And then I've got one patient who vacuums compulsively, and his wife isn't so sure she wants him to stop it. So it comes under the category of hobbyism, where people stay up
Washing clothes.
Yeah, right. They knit and make quilts and things like that, and scrapbooks. I've had all kinds of interesting things, and these don't necessarily hurt anything, but it's something we want to keep an eye on anyway. So, yes.
I read that when some people have got the impulse control disorders, that when they go off of medication to try to relieve them, that they still are left with the disorder, even though they discontinue the medication. That it doesn't necessarily.
Well, so the question is, if these things, if we think these things are medication-induced, these compulsions, do they go away when you stop the medication? And it kind of depends on the patient, and it also probably depends on whether they had some kind of impulse control prior to being on the medication, because the study that we participated in showed that a pretty good number. Do you remember how many? I think that they maybe
About 13%, I mean.
had it before dopamine therapy.
That I don't know.
They think it's estimated that at least 4 or 5% of the population in general has some kinds of impulsive control disorder. And so if you add a medication on top of that and then you take it away, it might not completely go away. But sometimes it goes away dramatically. It's just amazing. It's just gone. I had one lady today who was kind of a conflict of interest because she brought me a very nice pair of earrings one time, and I said, I really need to take you off this medication because you're shopping compulsively, but you just gave me this very nice gift, so it's kind of hard to tell you to stop that, But anyway, I did anyway. My conscience got the better of me, and I stopped the medicine. She came back today and she said, it's all gone. It says shopping is absolutely gone. So her friends aren't too happy about it. But,
So I think this is probably, there's probably a genetic component here that I think is pretty well established now, that there's family history of, say, addiction and that sort of thing, as far as the dysregulation syndrome, but also in this compulsiveness it seems to be somehow related to attention deficit disorder. All these things seem to kind of be related to the dopamine system. This kind of goes over my head It
goes over all of our heads. And there's something in medicine you don't understand. It means that the people who are writing about it don't understand it really either. So we know just enough about it to know how much we don't know, I think.
Medication using Prozac or Zoloft for Parkinson's disease medication, is that a good thing?
I think in general they're okay. I think that there's always this concern with the monoamine oxidase inhibitors like Azilect and Selegiline, whether or not there could be some interaction. We've been treating patients with these selective MAO-B inhibitors for 25 years now, and I don't think I've ever seen a case of this, an interaction with any of the antidepressants, but I think there's always this potential, and you got to be alert to that.
Yeah, I think I haven't been doing this quite as long as Dr. Tetrud, but I've never seen an issue with them. I think as long as they're used at the recommended doses, they're pretty safe. The pharmacies will sometimes have in their computer program that there are potential interactions, but I think as long as your doctor's aware of the risk and can monitor you and use the appropriate doses, it isn't much of a concern.
Are you saying that these medications are affecting sleep, or is that purely just a side effect of Parkinson's itself?
So are these medications, meaning the medications on this list, or?
Right.
So are you asking about just sleep disorders and Parkinson's, or sleep disorders caused by medication? Or which? Okay. Do you want to?
The sleep certainly is an issue particularly with the dopamine agonists. Excessive daytime sleepiness is a problem. And there's some indication that it might actually, even though it can cause these medications cause sleepiness during the day, that they may disrupt sleep and cause fragmented sleep during the night. So it is an issue, although sleep disorders, just in Parkinson's per se, is common. A lot of, probably several different sleep disorders that are associated with Parkinson's disease.
I think it's rare to meet a Parkinson's patient that does not have some kind of sleep difficulty of one kind. You know, REM behavior disorder where they act out their dreams and yell out at night, punch their spouse, or obstructive sleep apnea where they, obstruct their airway with their snoring and are not getting enough oxygen, or leg movements during sleep, and there are all kinds of sleep things. It's worth a good discussion with your doctor about sleep, because Parkinson's patients are notorious for having good days and bad days. So I always try to ask my patients, what predicts a bad day for you? And the most consistent thing I hear is poor sleep the night before. If your sleep is not good, your Parkinson's, your motor function will not be good. So you have to really work on tuning up your sleep. Very, very important. The other big thing that makes Parkinson's worse is stress. So every single patient I have says, when I'm under stress, this tremor gets worse, or I can't walk, or I can't think, or whatever. So stress and sleep are really important things to get under control.
What is it about sleep that causes the constipation and the blood pressure drop? What is it in the drugs that cause that?
Well, it's again, the Parkinson's disease, without any of these medications, can cause constipation and problems with blood pressure. But it is true that when we add these medications, levodopa, the dopamine agonists, or anticholinergics, they can actually slow down the motility, gut motility, further. So it's unfortunate that that's kind of an add-on cause of constipation, and that's why it's such a struggle. And we have, every week we have probably hand out about 20 to 30 sheets on constipation and strategies on how to deal with that. But it's a major problem, no question about it.
And then the blood pressure too. The blood pressure decline tends to be caused by the dysregulation of the autonomic system that Dr. Tetrud was speaking about. The part of the system that unconsciously is going around controlling your blood pressure and heart rate and all that sort of thing can be altered in Parkinson's. And then that drops your blood pressure, especially when people go from sitting to standing or lying to sitting. And then you put these medications on top of it. And dopamine is just chemically tends to drop blood pressure. In fact, it's used in the ICU for that all the time. People get on a dopamine drip. So dopamine chemically can drop your blood pressure. A lot of the medications we use can drop your blood pressure in a condition where you're already prone to have low blood pressure. And sometimes people are still on 3 antihypertensives when they start having this trouble. So then we say, well, go back to your cardiologist and see if any of this medication can be lowered or stopped even. I always joke that Parkinson's is one of the few things that can, in some patients, cure high blood pressure. Not really curing it, it's just replacing one problem with another. So.
Sir.
Orthostatic hypertension.
What we were just talking about.
Right. Orthostatic hypertension means when you stand up, gravity tends to take your blood to your feet, more or less, and so you have a drop in blood pressure. So it's the drop in blood pressure on standing. It changes its position. That's what it's.
I'm having the opposite problem. I've been on antihypertensives and blood for over 10 years, and now they don't seem to.
Could be a lot of different things. We don't usually see increased blood pressure in Parkinson's, but it could be that there's some dysregulation of the autonomic system. For something like that, though, I always say, look at the other potential causes of that first before you blame it on the Parkinson's, because it's not one of the more common things we see. Any other thoughts about that?
Yeah, I think blood pressure will vary. So, when a lot of the patients come to our clinic and traveling down 880 or
Highway
280
17.
or Highway 17, their blood pressure is generally up because it's stressful. But
Hypertension.
Yeah, but right. But it can be variable.
My husband has had quite a few syncopated headaches, but he's always sitting. He's never moved physically. He could just be sitting there in the chair, and all of a sudden I look at him and I can tell. And then.
Okay, so syncope means not getting enough blood to your brain, so you're going to faint. And so this is what often happens with the orthostatic hypertension, where you stand up and your blood pressure drops. So this gentleman's having it while seated. And so that can happen with the kind of orthostatic hypertension we've been describing. However, It's a little bit less common than the kind where you stand up and feel like you're going to pass out. So in this age, a lot of times people will develop some kind of cardiac arrhythmia, which is separate from Parkinson's. So I always tell people, because even if there's a small chance of that, you want to go get that ruled out by your primary care doctor before we just say, oh, it's the Parkinson's. So you want to make sure that when somebody's sitting there, not moving, and has, you know, a drop in blood pressure, that there could very well be something else going on. So,
But he does have arrhythmia.
yep, and arrhythmia is probably the most likely cause.
And it rarely, you know, sometimes seizures can cause that, but certainly Dr. Brandabur is absolutely correct. I mean, arrhythmias can certainly cause that.
Can you touch on protein and levodopa?
Oh, okay, yeah, that was supposed to be my little talk. So protein and levodopa. So it turns out that levodopa is an amino acid, and it's trying to get into the brain, across the blood-brain barrier. And the blood-brain barrier just means that the type of capillaries, the little teeny blood vessels you have in the brain that keep stuff out of the brain that you don't necessarily want in there. It's a very mysterious concept, because some things, like dopamine, don't cross the blood-brain barrier, and you think, well, you need dopamine in the brain, so why would that be? So that's why we give levodopa, because it goes in there and it's converted to dopamine. So the levodopa has to cross into the brain to do that. Every time you take an oral carbidopa, levodopa, or Cinemet pill, that levodopa has to get into the brain so that it can be converted to dopamine. But if you eat a lot of protein, that's also broken down to amino acids, and all those protein molecules, those amino acids, are also competing to get into the brain so that they can be used for building blocks for things the brain makes. So if you take a levodopa just after you've had, one of my patients always says she has trouble after a pulled pork sandwich with baked beans. So it's a double load of protein. Baked beans have a lot of protein and the pork has a lot of protein. Her medicine does not work as well at that time. So I don't tell everybody to avoid taking their levodopa with meals, because I think in the beginning it's hard enough to just take a medicine 3 times a day, and it can cause nausea. So I tell people to take it on a full stomach in the beginning. But as time goes by, if they start to get what we call dose failures, where the medicine just doesn't work as well, then I start saying, does it seem to happen more when you've had a high protein meal? Some doctors will say, you know, start from the beginning. You have to take this medicine on an empty stomach. I don't know what you do, Dr. Tetrud. Do you emphasize the taking the Cinemet an hour before meals right from the beginning, or?
Yeah, I sort of give people kind of a rule of thumb: 30 minutes before,
30 minutes
hour
before.
minute, or 60 minutes after.
Okay.
Something that.
So there's no
Kind of easy to
absolute way to do it, but some people, when the medicine doesn't work as well, we always start to say, well, gee, is that because you have a lot of protein in your system? Doesn't mean everybody has to avoid protein, and doesn't mean you can't eat protein. The other thing is, a lot of people don't know what protein is. Like, they'll say, oh, I don't eat any protein. I never have red meat. Well, do you have chicken? Oh, yeah. Do you have fish? Yeah. You know, do you have beans? Yeah. Well, those are all sources of protein. So you sort of have to get a little dietary education about what protein is so that you can regulate it. And of course, you need protein to build strong muscles and healthy tissue, so you can't just stop eating it. But a lot of people do find that protein will interfere with the workings of the carbidopa levodopa. Yes, in the back?
Is there any publications that address that issue?
Any what to address that issue?
Publications.
Publications that address, oh God, unfortunately there are too many of them. I'm sure if you look on the internet, if you get the nutrition book from the NPF that you can get from their website, all sorts of places will tell you to avoid protein with your medication. In fact, I think it's almost hysterically over-addressed, in my opinion. Yes?
What about sugar? Is there any correlation between eating a lot of sugar and making symptoms worse?
Eating a lot of sugar and making the symptoms worse? Well, I have one answer. You probably have. I mean, like, one answer is that I think a lot of Parkinson's patients will eat sugar as a quick energy source, because a lot of them feel sort of fatigued and low energy all the time. So I have people who never crave sweets in their lives that are hoarding stuff in their bedrooms, you know, because they're craving sweets. And so what happens then, if you eat a high sugar meal, then your blood sugar peaks, and then your body has to put out a lot of insulin to deal with that. Then you get this crash. So you're going to have really low energy about an hour after you eat a big sugar fix. So that's one thing. And then diabetic patients, when their sugars are out of whack, they will say that their Parkinson's is worse. So those are the 2 answers I can think of. Can you think of anything in particular?
Yeah, I agree with Dr. Brandabur. I think that A lot of my patients, they'll get up at night and they'll raid the refrigerator for ice cream. And so like the medications.
Not the fruits and vegetables.
No, not the fruits and vegetables, ice cream. And it seems like, the medication may actually stimulate the Twinkie center in the brain, but, it's certainly, the dopamine agonists, again, I think binge eating or the urge to eat sweets for some reason. This is anecdotal. I don't know if this has been reported, but so many of my patients really just love sweets. But I don't know if that's the medication or if it's
Or the
Parkinson's.
disease. The age-old question. Okay, we get one
One
more
more
question.
question.
Make it a good one.
This gentleman over here.
You were talking about the ANS. I can't eat a meal in the morning without triggering something that starts my blood pressure going down. What research projects are underway that can benefit me? I'm sure I'm not the only one.
Well, certainly the autonomic nervous system can be affected differently in different people with Parkinson's disease and also some of the variants of Parkinsonism. And you're absolutely right, it's a major problem, particularly when it drops that low. We do have medications that we use, which you probably have used. Florinef, Midodrine is one of them, keeping well hydrated. Lisinopril. That's for high blood pressure.
Oh, do you get high blood pressure at night? Some patients get really low blood pressure during the day and then the blood pressure will go up at night when they lie down. So we may have them on medicine to bring up the blood pressure in the morning and then to bring down the blood pressure at night. It gets very complicated.
The doctors seem to get excited about the high blood pressure, but
It's the low blood pressure that's most disabling. Yeah, that's a common problem. There's actually a new drug that's being studied that we participated in the study a couple of years ago called droxidopa. So I don't know if that's going to be coming on the market anytime soon, but there are studies going on to address this issue because orthostatic hypertension is very, very disabling for a lot of patients, and you're not alone certainly in that concern.
I will die of low blood pressure a lot sooner than high blood pressure.
Well, hopefully you won't die of either.
Systolic has been up to
Yeah.
200.
It's difficult. It's a tricky problem. So, well, I think we are done with questions. Thank you very much.
Yeah, thank you for your
And,
attention.
Good luck to all of you.